Hi, hello everybody, and welcome to the CMH Family Medicine Top Tips and Tutorials. We're going to delve quite a bit into mental health, and we have 5 little tutorials that's going to be specifically around psychosis. And I want to start off with just actually talking a little bit in terms of identifying psychosis when you have a patient coming in. And sometimes we muddle up psychosis with people who are just confused or muddled. So there are 3 sort of altered mental states, and this is from the Advanced HIV Clinician Society guideline on HIV, but it serves us very well. So remember, patients have delirium. That's quite often very much linked to a physical cause, and these are people who are very ill, and because of their illness, they have confused thinking or reduced awareness of the environment. We can differentiate that from dementia, which is more your slow neurocognitive processes. And these are symptoms that will affect memory or normal thinking, communicating, their ability to reason, their social ability, and it must be severe enough to actually interfere with their daily life. But psychosis is quite different. And what you're looking for in psychosis is a gross impairment in reality testing. And we're going to go through that in detail. And the big thing that's usually very specific around psychosis is that patients are actually very conscious. They're very awake. They know where they are. They quite often know what's happening in their environment, but they have very little insight in their own impairment in terms of reality testing. So let's delve into that a little bit. So I'm not going to cover delirium and dementia today. We're just going to look at psychosis. And when you think about psychosis, there are basically 3 key features that tells you a patient is psychotic. And one or more of these will make you think in terms of psychosis. And the first is patient having delusions, or the patient having hallucinations, or the patient having disorganized speech or disorganized behavior. And of course, the symptoms of psychosis, so psychosis is like having a cough, it's a symptom picture, it can be due to a mental health disorder, but it can also be caused by a medical condition. So a medical condition can cause delirium, which is your confused, muddled patient, but you can also have a medical condition that can present in frank psychosis. And the same with substance abuse. So substance abuse can also make a patient muddled, but you can also get a classic psychotic picture. And actually, it's quite easy to see when somebody is psychotic if you look for these particular symptoms, but it's much more difficult to tell what is actually the cause. And that's not so easy. So I want to just look at these symptoms in a little bit of detail. And when we talk about a delusion, it's somebody having a false belief that cannot be explained by the patient's culture or education. And the big thing is that you cannot have a discussion about this. You cannot persuade the patient. It doesn't matter what evidence or what the opinion is of everybody else in the room. They are very, very clear about this. And they can be bizarre. Sometimes people have just bizarre delusions, but sometimes the delusion might not be so bizarre. It might even be probable. And you have to sometimes get other input to find out whether this is actually happening. But it's not so much the nature of the delusion, but this extreme fixated view of it with no ability to moderate it. And look, there's a whole range. We're not going to work through the whole list. Usually, if you do write the delusion down, you would try and identify what kind of a delusion. And probably the most famous is our persecution delusions, where the patient believes they're being hounded or followed or otherwise interfered with. But there's a whole range of different kind of delusions people can have. It's important to distinguish these from overvalued ideas. So, for example, you can have, especially within the political framework, you might have somebody that believes their own race is superior to another race, and you might think that's a rather bizarre idea. And it's a little bit to look within the context to not make sure that you're just taking somebody who has an extreme prejudice and consider that a delusion. Our second big symptom is that of hallucinations. And so that's a false sensory perception. So you see something or hear something or feel something or smell something, and there's no sensory stimulus. So usually another person are not able to see or hear or smell the same thing as that patient. So an hallucination is always abnormal, but hallucinations does not always mean a patient is psychotic. So if you, for example, have an hallucination as you're falling asleep or as you're waking up and you see something strange, and you get a bit of a fright and then you realize, no, actually, that was probably not real. That's not an hallucination. That's not psychosis. So you had a bit of an hallucination, but it's something that happened due to a disturbance in your consciousness. So it will only count as an hallucination if the person is fully awake, fully alert, and therefore are seeing things and hearing things that are not there. And the second, probably the most important thing, is that the patient lacks insight into the fact that it isn't there, and you can't argue them out there. So there's almost a delusionary, I am definitely hearing something, or I'm definitely seeing something, but other people cannot see it. So that's different from illusions. So, for example, with drug use, sometimes people will see patterns changing or things strange, or they mistake something they're seeing for something else, and that's not an hallucination. And then you can look at the kind of hallucination sometimes does give us clues. So visual hallucinations and some of your tactile hallucinations is much more likely to be caused by a medical or a substance use issue, or so more to do with delirium. The classic psychosis one is these auditory hallucinations. Somebody hears somebody speaking in their head. So the third big symptom is symptoms of disorganized speech or behavior. And actually both of those are partly, especially the disorganized speech, is actually evidence that there's disorganized thinking. So the disorganized speech is just showing us what's going on in this patient's head. And that can come out in the way they speak. So that might be a flight of ideas from them jumping from one topic to the other. They might be, you're talking about something and then they get distracted into something that's completely unrelated to what you've actually just said. They might actually speak gibberish and make up new words, or have a strange words that they are talking. And the biggest thing is you can't really follow the conversation. You can't really make sense of what they're saying. It doesn't really, you're struggling to actually understand what they are talking about. Disorganized behavior is to do with physical actions that doesn't make sense. So it's important to distinguish these from a behavior that's a bit weird because it's due to their delusion. So if they have a delusion or a hallucination that there are spiders on the floor and they're running away from the spiders on the floor, that's not disorganized behavior. The disorganized behavior must have no particular goal in mind. So somebody stripping naked in the middle of the street, somebody making strange signs repeatedly, or standing in strange or weird positions for no apparent reason. So those are the three main cardinal symptoms of psychosis, but we also have a watch out for negative symptoms. So negative symptoms are positive symptoms always add something to what somebody is doing, but negative symptoms means there is less going on. So, for example, a reduced range of expression of emotion, or a markedly reduced amount of fluency of speech. Avolition is if they've got a loss of will to do things. Anhedonia, so not enjoying, a lack of enjoyment in things, and a lack of social interaction. So there's sort of a blank way of interacting for the world. And we have to obviously make sure that this is not depression or some other thing that is causing this dullness. But these negative emotions are quite important. And it can be difficult because, of course, sometimes people do strange things. It does not necessarily mean they are psychotic. But these negative symptoms can be an early marking of chronic psychotic disorder, or it can also be present after somebody's recovered from a psychotic disorder. And they need as much attention and care as the psychosis itself. Then, of course, a catatonia. That's the real, where it gets really a little bit stranger, much more uncommon. And catatonia is a symptom. It's not a condition, and we use it as a specifier. So you would say somebody is diagnosed psychosis, you will have a psychotic diagnosis, and then you would say with catatonia. And the various possible features of catatonia is very wide. Again, we're not going to cover these in detail. They include postural things, so people standing in positions for long periods of time and quite uncomfortable positions. And when you move the arm stays where you take it. They call that waxy flexibility. Can also come out in certain mannerisms and ways that they speak. So they might repeat the words you say after them. They might repeat your mannerisms. And right down to the stupor, which people sometimes associate with catatonia. So there's a whole range of different things, and you will just add that in as a specifier for that particular psychosis. So just a couple of additional things. So usually psychosis are almost always must be accompanied by lack of insight. So the person doesn't realize that what they are believing or seeing is not real. And therefore it's always accompanied by poor judgment, difficulty to make decisions. And often patients can feel quite threatened and quite confused by what is happening. And aggression is a possible risk, and then a risk of harming themselves and others. It's not actually that common, but when it happens, it is potentially very unpredictable. And it affects cognitive function. So if you're psychotic, you can't think properly. So it affects your memory, it affects your ability to learn anything, obviously, and very important, it affects executive functions. So a big feature of psychosis is you're not going to be able to work, you're not going to be able to maintain a relationship, you're not going to be able to manage life if your brain is not fully online. So let's look at a quick differential. And these are all the psychotic disorders that are actually listed in the DSM-5. So there's not actually that many different things that you're going to come up with. It's important. So kids, it's mostly we are trying to figure out, is it schizophrenia or is it not schizophrenia? And there's a few things that we need to think about before we think about schizophrenia. So you do get something called a brief psychotic disorder. So this is somebody has one of those basic psychotic symptoms, so at least one of those three basic important ones, but it lasts less than 1 month. And usually they were fine before it happened and they recover fully and it's fine afterwards. And these are often got an event that might trigger it. So the typical one is pregnancy. So a woman during her pregnancy or postpartum period suddenly having a period of psychosis and it goes away completely. And that we would call a brief psychotic disorder. Then you've got like sort of a stopgap diagnosis, which is schizophreniform disorder. And this actually is the same criteria for schizophrenia. So it will look like schizophrenia, but it's for a much shorter period of time. So this might be something where you look at them, they've only had symptoms for 2 or 3 months. You're not entirely sure if that is actually schizophrenia yet. They don't have that classic buildup of negative symptoms before they got sick. And some people with schizophreniform disorder will also fully recover, although there's got a much higher risk that within the next 2 or 3 years, it will go into fully fledged schizophrenia. So again, if they've had symptoms for 2 or 3 months, you might diagnose schizophreniform disorder. If it completely recovers, then that's what will stay on the diagnosis. Or if it continues more than 6 months, then you might translate that diagnosis into schizophrenia. And so schizophrenia, very important. They must have had at least 2 or more of those 5 psychotic symptoms for more than 6 months. And we'll cover that in a section on schizophrenia. Then there's another very difficult to diagnose schizoaffective disorder, and that's when you have a complete combination of schizophrenia and one of your mood disorders, either bipolar or depression. Difficult to diagnose because it might be psychosis, depression with psychosis, or it might be a person with schizophrenia that's a little bit depressed, but there needs to be a very particular way into how these two interface, and certainly not the kind of diagnosis that will be made by a GP or family physician. You'll need a psychiatrist to help diagnose this. And then interesting, actually very uncommon, there's something called delusional disorder. So this is somebody who only has delusions, no other symptoms of schizophrenia, and it doesn't affect their functioning unless it's got something to do with that delusion. So they're able to get on with their lives as long as that particular delusion does not get triggered. And then you have actually in the DSM-5 psychotic disorders that is due to a medical condition. So particularly, again, this is not about delirium. This is specifically about psychosis. You have substance-induced psychotic disorder. So again, frank psychosis, not delirium. And you would link it to a particular substance. And usually it will have to be, you took the substance, they became psychotic, you stopped the substance, and the psychosis went away. And that's quite useful because sometimes patients, obviously with schizophrenia, are also using substances, and you have to try and differentiate the two. And then there is, of course, the other specified that is all the little things that doesn't quite fit into any of these basic definitions. So in the next, we will be talking much more about schizophrenia in some of the TUTs following. We will look at how to understand schizophrenia, diagnose, and treat it.